right. Welcome everyone to this podcast, video podcast. We're calling it Toe to Toe. The goal is to bring together experts in the field who may or may not agree on everything, but certainly agree on the fundamental things. My name's Hodges Davis. I'll be the moderator here. My two toe-to-toe experts are Justin Kane and Mike Aynardi, and they actually were residents together, been out in practice for 7+ years after their foot and ankle fellowship. And today we're going to talk about complications of neuropathic problems in the foot. So we'll talk about Charcot, we'll talk about fractures, and the goal of this is to say it's time to bring the treatment of this difficult patient population into this millennium. We have so much better options, both surgical and non-surgical, to treat these folks. And so our goal is to have fun with it, but more than anything is to bring the realization that we've got to up our game. All right, so the professor has told us about where we are in our basic science, but now we're going to really talk about cases. How do we help patients? How do we give folks tools on how to help folks? So, Mike, we're going to get you to start, and I may get Justin to comment on every step of the way. So why don't you start with case one?
All right, Justin. So what can happen in a cast? 67-year-old diabetic neuropathic patient. We got a phone call saying, hey, this fracture's gone bad. Well, very well-controlled diabetic. A1C was 5.2. She's had neuropathy long-standing for 15 years, actually from Guillain-Barré syndrome, and also has a history of osteoporosis. So she had a fall, broke her ankle. It was minimally displaced, trimallar fracture. They've put her in a cast, well-padded, and because of all of her medical issues, she was actually at a nursing home. So she came.
So the plan was to treat her in the cast.
Yeah, non-surgical.
Didn't matter that if this is a trimal that maybe would have been fixed if it wasn't neuropath with Guillain-Barré.
Correct.
Okay. All right.
And when she came back to their fracture clinic, she saw one of the other partners, took x-rays, and ended up said, this is displaced. We got to go to the OR, fix this. And he gets her in the OR, and he cannot reduce the fracture.
Closed.
And then he attempted to open because she had this wound that we discussed earlier in our talk. And so he washed that out, debrided it. You can even see here his screw holes where he tried to put the plate on. He tried to push-pull. Pretty good community trauma surgeon from an outside hospital, and just could not.
That's what the incision is
on the lateral side. Yep, on the lateral side, and he just could not get it reduced. He called one of my partners, who's been in trauma practice for 30 some odd years, and they kind of discussed amputation on the phone. And fortunately, I was working at the same time. He came down the room and threw up pictures on his cell phone and said, "You think we can salvage this limb?" And I said, "Yep, get her here. Let's try it."
All right, so Justin, you're in the middle of, you get that same call. You're a community orthopedist, taking call, and you can't get it reduced. It's been 4 weeks. Do you keep playing with it, or do you do a primary arthrodesis? I mean, what in this mode, if you get the call, friend of yours down an hour away, I'm in the OR, what do I do now?
I mean, for this, even going in, looking at how this looks, you have to be thinking, I'm not going to be able to get this reduced. And not only that, you see there's either that's callus or that's Charcot. And it's one or the other, and at this point, it doesn't really matter. That is not going to do well with the reduction. So for me, I wouldn't even try to reduce this. This is a primary fusion, irrespective of whether you can reduce it or not, because of the bone stock that's there. And I think the Achilles is fighting you. The fact that it's been out for so long, it's fighting you. you have to go right to fusion with this, and you can't stop at the ankle. And I've seen some of my colleagues in the community look at something like this. They fail the ankle fracture, then they fail the ankle fusion, and then they're like, well, now what do I do? Just go see Dr. Kane because he'll figure something out.
Now, are you going to do flat cuts here, or are you going to?
I'm going to flat cut this because I'm going to do a lateral approach rather than try to do any type of other approach, because I think the anterior incision, especially with the anterior tibia perched like that, I think you have better soft tissue coverage. You have adequate bone to take that you can use as bone graft. And if you have trouble with any type of skin tension, you can take the fibula out and you have a lot of soft tissue redundancy to close.
And do you prepare the subtalar joint?
Always.
Okay. All right.
Moving on. So I love your plan, Justin, and that's exactly what I did. And I explained to them at a time, look, I think we need to shorten you to get this closed. I called our plastics guy on call who came in the room, and I think he dropped his jaw. I helped pick it off the crown, and we said, let's go to work. And so I felt that I was really concerned when we explored both incisions. The fibula was very soft and mushy, and like you said, is this Charcot? Is this from the fracture? Is this from superimposed infection? You know, who knows how long that tibia was eroding through the skin? It could be 2-3 weeks that infection was going on. And so I said, you know what? We're just going to get her lined up, and we're going to try to fuse her in a frame. But I need to get soft tissue coverage, and I need to shorten her. And I chose dynamic framing here because I felt that while I could get her back out, was putting a ton of tension on. And the plastic surgeon, with her medical history, suggested we just try a split thickness dermal allograft over a pretty small hole. It's about, you'll see the pictures here in a few seconds. It's maybe 1 centimeter in width and then 3 or 4 centimeters in length. And I said, hey, look, I can bring her talus posteriorly here, which you're going to do if we're doing a hindfoot fusion anyway, slightly to get those tarsal joints in better mechanical advantage. And by the way, it's going to help us probably close this. And then we could bring her back to optimal position with the frame and use that to our advantage. And so I chose dynamic framing here. I think static framing would have been fine. I don't know how you two feel. Would you have gone just static and lined her up in the right spot?
So these are cases that, again, I have a high threshold to suspect, or low threshold to suspect infection. These are the standard ones where I take a chest tube, I make an antibiotic nail, I use that to hold some stability so none of the bones spit back out, and then I'll use static framing, but I'll compress with the static frame weekly.
Let's unpack that a little bit. Antibiotic nail is you coat a standard nail.
So I don't do it that way.
Okay.
So what I'll do is I'll take a 38 French chest tube. Mm-hmm. I'll put a ball tip guide wire in it, measured to 150 millimeters.
38 French is going to be how much diameter? Just how?
Roughly 12.
That or that.
This is the difference between the professor and
divide by 3.
Yeah.
East Texas.
Yeah.
BS.
I'm Central
All right,
Texas.
All right. So
It's honestly the same size as
how much do you ream it? That would be the more pertinent.
That's
question.
a great question. So a 38 French is about a 10 millimeter nail if you're going to use a regular nail. So I will ream to 10.5, and then I'll use the ball tip guide wire. I'll inject cement that is usually Tober cement, and I'll put 2 grams of vancomycin in it to get MRSA coverage. I'll put a little hook on the end of it. I'll impact the hook into the calcaneus so you can come back later and take it out.
So you put a metal rod with a hook into it. Okay.
Exactly.
So you can get it out. Got it. Okay. That's a question that'll come up again. So, all right. So you did, and I think it's dealer's choice here. I would probably keep cutting until I got it and use and not use an antibiotic nail. I would have used a just a frame, but a static frame. I probably would have done temporary fixation and then put a static frame on it. But I love this technique because it's much more friendly to the soft tissues for sure.
Yeah.
Okay, let's see what you got.
So she grew out Staph luginensis and Enterobacter, and then the fibula was positive.
Gesundheit on the Staph luginensis.
Yes,
Yeah,
thank you.
Yeah.
And so she ID saw, we have a fantastic ID team, and I think, if you're going to get into Charcot limb salvage, especially infected open sores. You need a good ID. I mean, they see the patient with us every clinic visit during that treatment phase.
Now, there are some people with frames that say the frame's going to fix the fracture. You've cut it out. We don't need IV antibiotics. I personally think if you have a positive bone culture, you're going to have to treat them. What IV or PO, you know, people are going back and forth. You got to have to treat them for a while with antibiotics. Both of y'all agree with that?
Yeah, I agree.
Okay.
I usually, because we are disadvantaged where we don't have a lot of academic infectious disease doctors, I usually try to run the show, and I'll tell them at least 6 weeks of IV, followed by at least 6 weeks of oral. And if they're like, oh, they look good, their numbers are down, I was like, you know, this is the shot. Because if it doesn't work here, you're cutting it off. And yes, if they get a PICC line infection, let's pull it. But most of the times they don't.
Yeah.
So
that is a great point, right? This is a one-shot deal. To get a fusion or a stable non-union, to get rid of the infection, and then to have soft tissue if our goal is going to be to get them in a shoe and a brace. Okay, so let's see what you got.
Moving along. So here she is, right when we're leaving the OR. We were able to close her. We did use a dermal allograft. Plastic surgeons help with that part. We got the majority of the wound closed. You can see here, zero form over the front. We did prep out our subtalar joint and did flat cuts on the ankle in preparation for fusion. My intent was to leave her in the frame to fuse her definitively. You know, here it is with the plastic surgeon as their pictures at about 10 days. And I was kind of going, oh boy, when do you want to go back and wash this out again? But her inflammatory marker, CRP, had cut in half after the first day. So
that a lot of times that's what it looks like when you've acutely shortened them. They've got that little accordion look to it. You don't know how to analyze it. Yeah.
They felt good about it, and so I said, okay, I'll be patient with you because the infection seemed to be in the right direction.
Now, Justin, in your case, this patient's coming back to see you once a week, and
they come back once a week, and they have my cell phone to text me pictures.
And the plastic surgeon is
you're looking at him
doing boob jobs.
You're
okay.
looking at him.
Right,
I do the plastics.
All right.
This is her about 3.5 weeks out here, and you can see she has this kind of S-scar. Plastic surgeon lifted up and debris, a little bit of it you can see on the bottom part of the picture. She's got
that's where the dermal allograft is.
Yep. And you can see his PDS line in it there, and you can see on the bottom she's got pink granular tissue. It wasn't proven down to a joint, so he said, no, let's just be patient with this.
Swelling's gone away.
Yep.
Imagine. That is the beauty of the frame, isn't it?
Yep.
I mean, everything is immobilized, and you can see everything. So it's not like you're in the cast and you don't know what's going on in the cast, as we've talked about.
So I'm going to ask a question to y'all, because I see the Shands pin up there. Do you still do Shands pins?
So her A1C was lower than 7. So in this case, I did, if there's thin wires above there.
Okay.
But if their A1C is above 7, absolutely not. And your group had a real nice paper on that. And I think I'll show one of my mistakes, I think, later, where I didn't read that paper early enough in my practice and had a few broken pins. But I think that's a great point to bring up.
Yeah, the paper he's referencing is we put our cases together with Mickey Penzer's and found that the half pins had a higher incidence of pathologic tibia fractures. So what we found is if they were outside of the frame, that was where you had the problem. If they were inside the frame, it wasn't so bad. I don't use half pins in Neuropath, but based on that study, but Penzer will tell you the same. But Carol Jones, my partner, will use them inside the frame. And
that's how I started. I trained in fellowship with somebody who trained with y'all, and half pins inside safe, half pins outside not, until I had the one that came back to my clinic after we took the frame off, and he fell on his way out to his car and broke through the half pin site.
We have a few of those.
And so at this point, I started to run a program. You can see we're beginning to bring The tail is forward. There's not a ton of bone formation yet and regenerate there, but the fibula is doing something. And then she comes back. I think we're seeing her about every 2 weeks. And now you can see that area where the granular tissue was, where we kind of peeled some of the scab off. Looks good. And kind of hard to tell in this picture, but you could almost lift and flake it up, and there was pink, healthy skin under most ends of it. So we said, hey, let's keep watching. All the while, we're closely monitoring her labs, IDs, plastics ID, and myself at every appointment. Here she is a few weeks past that, and you can see she's in a pretty good location. There's more callus off the fibula. There's something happened in the central portion of the tibia-talar joint. And so at this point, we said she was in a nursing home, had been there for now going on 5 or 6 months because her husband was ill, couldn't take care of her. Initially a cast, couldn't get around with that because I made her not weight bearing. Now she's got this frame, which I wasn't letting her put much weight on, only a transfer. And we talked about her labs had all cleared. ID had signed off. She had her antibiotics. And I don't know if this, I think it's a great discussion. I think we've talked about similar cases before, is why not just leave the frame on for 3 more months? But I think there is a psychology to having a frame on too long, and that this woman had kind of had it. So I offered her taking the frame off, checking cultures, and if they were negative, then returning in 2 weeks to do a hindfoot nail. Ridiculous or no?
I mean, I think maybe I'm a little more aggressive. Now, she had an active infection, but if they don't have an active infection and I'm using a frame, I will do that in one stage. I'll take the frame off and put the nail in. I think that's totally fine. What I would say is I always get a CT on these patients before taking the frame off to make sure you have at least what they call spot welding. 50% of the joint shows some type of union. And then you get that last little bit of compression through the nail, and you're usually home free.
Yeah, if I'm going to do a 2-stage, it's because when I take the frame off, there's a non-union, and then I'll do it 2-3 week, and then come back and rod them. But I am underwhelmed at my ability with CAT scans to really tell what's going on. There's just so much metal, in particular with the rods, and so. In addition, in our weight-bearing CT, it won't fit, so I have to send them to the hospital, which goes against my better judgment. So
we went for it, and here she is. Her cultures were negative. You can see she's kind of got some fusion mass at both the tibia-talar joint, subtalar joint laterally there, and her fibula is kind of forming a synostosis there with the tibia. And then a few more weeks later, she's solidly fused. And plastic surgeon was right. That thing flaked off, and we never looked back. And she's actually in just a plastizote line diabetic shoe now.
Now, when you went back, did you do anything to the joints, or just or maybe squirt some biologics, anything in that?
Yeah, she got PDGF through tiny little lateral incision. I did not re-prepare the joints because we did it stage 1, but there are times in the setting of neuropathic fracture where I'll make tiny little incision, either use small curette or burr, and then just irrigate debris. Small incisions, but it helps you. I think just running the nail up sometimes is appropriate, but I think in this case, we had come so far and she was doing so well, I didn't want to chance it. So
yeah, that's why I do the CAT scan when I got the frame off. When I'm in that pin holiday, if it looks like I've got an impending non-union, then I'll do a little minimal and then inject biologics. And you mentioned PDGF. I think PDGF in neuropaths is a game changer. It just really gets things moving, and so that's awesome. That's a great case. Great case. You'd be proud of him. When you'd say,
I want to come across the table and give him a hug.
Yeah, it is a beautiful thing. It's a beautiful thing.
All right, am I going to keep going here?
One more.
One more. Okay. All right, Justin. So got a call New Year's Eve. I was on call, and the residents said, hey, Aynardi, we're looking. We think we see the talar head, and there's a bunch of pus draining out. Real big guy. poorly controlled diabetic, like 7, 8, A1C, history of a stroke on that right side. And so he did have an AFO he was wearing to help pivot and transfer. And here's his leg. Well,
So is this new, or has this been like that and he just developed an ulcer?
there was a little callus there maybe a week ago. They can't.
Okay. Is it reducible?
The residents were unable to reduce it.
Okay.
I was unable to reduce it in the ER.
So this is classic Charcot peritalar dislocation, and I love that you're showing this because I'm going to show some acute ones that don't have this, and why we go early on this, because the talar head's going to stick out of the skin at some point because the patients can't feel it, and now you have a patient who is neuropathic but also a stroke patient. This is not a patient who's going to be able to advocate for what's going to be best for them. This is a tough case, but the thing I love about this case is, as you bring everything back over, you do have a lot of play on that soft tissue medially when you relocate them because they've stretched out that way. So if you can get this reduced, you can even cut the talar head off if you're concerned about infection, and you can also do a hindfoot fusion.
Yeah, I mean, that's been my experience. The other is to just take the talus completely out, and then it swings around very nicely. Yeah. All the pressure's off, and then you can treat it in a frame. And it's fun to show residents that it's just not that hard. Once you take the talus off, you can do anything you want with this. In particular, if they have calcaneus, and we'll show cases all the time where the calcaneus is gone too, and then you're really in a pickle. But this looks like you've got calcaneus coming.
What when you guys get the phone call, and I got it on him, is where there's air in the tissues. This is a necrotizing leg. In fact, in our hospital, there's a protocol where the general surgeons see the patient first if it's a necrotizing infection, or presumed. So they were ready to take this guy to the OR for an amp that night. And at what point, or do you ever pull the trigger on amputation acutely, or is there no such instance? So he did have all his labs were up. White count was like 17, I think. ESR through the roof, CRP through the roof.
Lactic acid
was normal.
So it's not gas gangrene. And I think that we have all these tools in our armamentarium if we're not using them. And if you're going to take this without that lactic acid being high, it's the wrong thing to do.
Yeah, I mean, my feeling is if they're, I mean, obviously is sick. Sometimes you get I've gotten consults in the ICU and they're in full diabetic coma, and then then you're stuck. But my preference would be to treat the infection, which means I would IND it. I would take the talus out in one, and then I probably would see how they do. And then if they look okay, then I'd come back and do a frame as a second stage. No one would ever fault you for treating the infection. I mean, this is a sick patient, and acknowledging that they're a sick patient. So that's probably on New Year's Eve. That's probably what I would have done.
So Hodges, I did cut the talar head first. I try to save as much length the limit possible, but even with taking the talar head, I have trouble swinging him around. I mean, I bent a cob just trying to get him over, and I said enough of this, so it made a lateral incision, took down the fibula, and there was a lot of pus in there, and so I just went right to talectomy. But you can see here, I think, Justin, do you have any criticisms of what I did with the tibia, I guess I'd ask?
So I would actually chamfer it the opposite way. I mean,
Yeah.
you beveled anteriorly.
I didn't really chamfer it posteriorly, and
Yeah.
I do now. And
You got to fit that posterior facet.
I agree. So what Justin's kind of talking about, and call it self-flagellation here, but I think a cut that's matching the inclination of the posterior facet, the calcaneus, it can be a really great surface area for fusion when you come back at a later stage. This is that area then packed with resorbable calcium sulfate antibiotic delivery devices, and you can see here they're spilling out from the talus one side to the other.
Chiclet suspension.
Yep. I don't eat Dippin' Dots anymore, and you can see here we were able to get him closed, and primarily through the shortening and removing his whole talus. Guy's huge guy. He's like over 300 pounds, and so yeah, he's all thin wires. You can see his some of his stymon pins sticking out there through his skin. So he was in the frame for a good 4 months. I talked to him about putting in screws. I didn't think it was appropriate at that initial stage. I do not have a CAT scan on him, but when we took the frame off, I always stress them with fluoro, and he had a very stable hindfoot tibia calcaneal fusion mass, and he had some motion through his tarsal joints. And I guess the next question I'll throw out to the group here is, when do you leave just the tibio-calcaneal fusion as enough and done, and when do you add additional sprues like that very first patient to try to get true pan-talar? I think I struggle more personally trying to get the pan-talar, and I think if the ankle and hindfoot are stable,
I think
we're
you're
good.
getting they'll spit those screws out because they'll get a non-union. I like having that, the so-called flipper foot, which gives you motion at that. All right, so Mike, you got a solid tibia-talar fusion. The question is there a reason to try to convert this to a pan-talar? Justin, what do you think about leaving the transverse tarsal-ish joint free?
I think you have a stable hindfoot. That's probably the hardest thing to get with any of our Charcots, because we know that unstable hindfoots tend to be the ones that you can't cast, the ones that have a higher risk of complication. I would leave well enough alone with this. One, it's fused the hindfoot. You can get them into something that's not a crow boot. But even more so, a lot of these patients like the motion that they have after they have that talectomy or a transverse tarsal osteotomy, where they still have some dorsiflexion, plantar flexion. You don't have to get them in a rocker shoe. You can get them into something because they do have motion in the dorsiflexion, plantar flexion plane.
All right. So you do that, and then 2 years later, they come back and they go, I am so short, it's bothering me. Do you lengthen them?
No.
I just had that this week. I had a patient from 2 years ago, same exact thing, talectomy, got him diffused. He had maggots when he first came to my office, and he says,
Yeah, I really appreciate you having to, they don't have maggots in Pennsylvania.
Not true, actually.
No.
Tyler has
Only
video.
In the summer.
Only in the
6
summer.
weeks.
Yeah. Only in the summer.
In Texas, it's everywhere. Cowboys fans.
It was great.
Come on.
So my MA, I don't know if she knew what she was getting into when she worked for me, because she came in, I'm in my room dictating, and she's like, Dr. Kane, there's something moving in his foot. I'm like, is it his foot? She's like, no. I'm like, is it maggots? She's like, I don't know. And I went in and I put a glove and picked them. I'm like, they're maggots. This is great. It's going to debride all the dead tissue. But but the point of the story, he's 2 years out.
That's a sell job if you can convince him.
Yeah,
That's great.
That's great.
This is great.
But he's got a little shoe lift. He took his daughter to a daddy-daughter dance. I'm like, yes, could I lengthen you? Absolutely. If it fails, you're no better off than when we started, and you may wind up with an amputation.
Okay.
If it be.
That is the standard Elizaraovian answer, right? Neuropaths do not give a great regenerate experience, or you've kind of stuck with that?
Yeah, I would agree with that completely. I have a trauma partner who does a lot of limb lengthenings, and when I first started, we talked about, hey, maybe we should try doing, proximal tibia lengthening, after you do your shortening and fuse. And I think I sent him 1 or 2 patients, and he looked right at their A1C, and maybe one was using nicotine, I'm not sure. And he said, yeah, let's just go with the shoe lift. And I think, the amount of time they're going to have to spend in a frame and the distance that frame's going to span if you try to do it all in one shot, I just think you're playing with too much fire.
Well, I haven't done it yet, but I think with the telescoping rods, I may do 10 in August and then retire. And we'll see what happens. I have a list of probably 12 that have just said, when you change your mind, please call me. And And my nurse who keeps the list, she constantly is saying, these people are blowing me up. They know you're retired, and
Stick around for another year after that because the current telescoping rods are not strong enough to let them weight bear.
yeah.
That's the problem with the current telescoping rods.
Well, we have a new one coming out, so we're hope so.
I would worry. I mean, I think if their neuropathy ends in true stocking and glove, you're probably okay to lengthen them from the proximal tibia. I'm just not. I think all the host problems we talked about, I think you're just safer with the lift.
Okay. All right. You had one more thing you were gonna.
Oh, just this, and this is him out of his. He's in a double metal upright AFO. He actually over time, and you can see I lost a little bit of correction as he kind of fused into a valgus position. He molded AFO. He loves it, and he actually ended up. He's pretty stiff. He does not have much motion. But like I said earlier, that's his stroke side, and so he was used to not having much motion, I think he and I got super lucky. You can see he's made a ton of bone. Look at the fibula there. It's just kind of like.
But just think about it. That's a great save. And the bottom line is you don't have to panic, right? No lactic acid. This is not flesh-eating bacteria. And that's what I constantly am saying, because they come in and they're going, oh, my God, I've got flesh-eating bacteria, because the radiologist reads that.
Air. It's the air.
And you just kind of go, okay, let's get over this little bump. And 5 days later, they look so much better and their labs look better. And then you can do a real reconstruction. The frame is an amazing instrument. And that's been my experience. Don't panic.
No need to sound the fire alarm.
Yeah, well, that's the police. They're here for me.
So, especially not on New Year's Eve. You don't panic on New Year's Eve.
Agreed.
Panic on Christmas Eve sometimes.
Yeah.
All right. You said you had something on the contact cast?
Back to this here. I think a lot of, I do believe there is a role in casting these patients. And we have, we're blessed to have a physical therapist who is trained in total contact casting. She also does some debridements as well. So she's certified in wound care. One thing she does, every cast appointment takes temperature of both sides. And I know this seems so simple, but I'll tell you, it works. If you wait to transition them out of that total contact cast to their double metal upright AFO, I used to go total contact cast Crow and then try to give them a double metal upright AFO, and now I just keep in the cast until their temperatures get close, and then go right to double metal upright AFO. I have yet to be burned on that, and I think it saves them the $2,000-$3,000 cost of the Crow, which they all hate. Anyway,
It's a coffin. It's a foot coffin. That's what I call them.
You love that term, but I don't disagree. I don't order Crows. There is fewer people who are doing contact casts well. It continues to be one of the highest causes, cast complications, of litigation in this country. So it's not without its challenges. That being said, I do the same thing. When I get them out of the frame, I put them in a cast. I just think it helps the swelling. It's all. The other thing I've added is an Una wrap as the layer, rather than in the classic contact cast it was the flex plaster, and the Una wrap is easier to put on. So that really does help the swelling, but it's weekly. I mean, you got to stay on top of them for sure.
Yeah, ours will do, she'll go bivalve, Una wrap frequently, and then she does every 2 to 3 weeks. We only have one girl, and we have a lot of Charcot in central Pennsylvania. So it could be our appointments could be spaced closer, but I mean, I'm taking what we got because she's doing a great job with patients. But I think, Justin's doing his own total contact cast, so you can do it. It's just a labor of love, I think, in the clinic. I don't think a cam boot with a diabetic liner is sufficient for most of these patients once you get them out of the frame.
Especially if they're in the perioperative or in the acute issue stage. The volume changes are dramatic, and I'd rather leave them in the frame for another month. I mean, that's what I've taken to doing. my cast tech will come in and go, she's not ready to come out of the frame, knowing that he's going to have to put them on every 5 days. So, yeah, you just kind of do it. Okay.
All right, JK, your turn. Let's get at it.